And now is your turn to really ask questions or basically give us views on where we are and what your requirements are. Before I open it out to the audience, what I'd like to do is to maybe ask each member of the panel to introduce themselves and then give a 2-minute statement on what they feel that the requirements are for their particular sector or for the wider sector as well. I know that Bill is just looking horrified. I hadn't warned him about that, Bill. I'm sorry about that. But I had warned Nadeem about it, so I'm going to ask Nadeem to start, so Bill can have time to think about it and so on. And yes. Nadeem's got a slide, so can we put up his slide, please?
For the next session.
Sorry?
That's for the next session.
Oh, is it on next session? Okay.
Yeah.
Okay, well, why don't you tell us what 2 minutes? Introduce yourself first.
Hi, I'm Nadeem Qureshi. I am a GP in Nottingham, Professor of Primary Care, and I run a research group around genomics and data science. So I'm going to base this on the evidence from what we've done. We've done several surveys in the past, including most recently with Imran, Will, and Jude. And in terms of what GPs want, what we've found is they probably often want the less effective modalities of education, like educational material, lectures. But what the challenge for us has been to actually engage them in the more effective modalities. So for instance, we've tried to do educational outreach, which is positive but very expensive, tailored patient-specific reminders on computers, which is also challenging in terms of the noise with reminders. And another aspect we've tried before is training the trainers. So you train individuals who train others. So in essence, there is evidence for what works, but the challenge is trying to get it into practice.
Okay, we'll pick up on that in a few minutes. Bill, why don't we take you to the more kind of your clinical genetics community and what's required for secondary care, healthcare work?
Sure. So thanks, Munir. I had written some notes. I'm Bill Newman. I'm a clinical geneticist based in Manchester. And as you've heard very eloquently from Annika, clinical geneticists are intimately involved in working with patients and their families in describing the value of genomic and genetic information. And we've been doing that for a number of years. And I think we have a task and a role to upskill our own workforce as we understand more about new technologies, about what some of the complicated implications of some of this information are. So when we're thinking about variants that we find difficult to classify or understand and those sorts of things. So there's a role there. But then it's very much incumbent upon, I think, clinical geneticists, genetic counsellors, laboratory staff, to reach out into mainstream medicine and to work with colleagues in other clinical specialties. And of course, as we've heard before, that genetics isn't equally relevant to all genetic specialties. If you're a paediatric neurologist or you're an oncologist or working in an inherited cardiac clinic, it's absolutely fundamental to what you do. If you're an orthopedic surgeon or working in A&E, it's probably less relevant. There may be some implications. I can just give an example very quickly of a project that I've been involved with, which is around point-of-care genetic testing in a neonatal unit. We're applying a cheek swab on every baby that's admitted to the neonatal unit, and then with this new kit that we've developed, within 15 minutes you get a result that tells you whether the baby's got a mitochondrial variant or not, and then you can decide whether to give them gentamicin or not. 1 in 500 babies will carry a variant that will mean they'll go profoundly, irreversibly deaf when they're given gentamicin. And so you can get that information very quickly and within an hour. Now, what we've clearly realised is that if a baby comes into the neonatal unit at 3 in the morning, you don't need a whole range of people to be trained on how to use the kit. You need the Band 7 nurse who's going to be assigned to that baby to know how to use it. And the work that we've been doing over the past years, we've been developing the project, is about the narrative of making sure that the staff on the units, both in Liverpool and in Manchester, where we're running it, absolutely believe in the value of the project. If they don't believe in why they're doing it, it just won't get done. You need that sort of personal engagement. Once you've got that, that's the first element, I think, of education, making people believe that it's relevant, important, and then they will seek out the right information. I talk too much. I'll stop.
Thanks very much. That's great. A practical example of where you're trying to apply that. Sue, can I ask you to...
So I'm going to make two comments, actually. They're related, but they are different. The first is, following the publication of the NHS long-term plan earlier this year, there's been ongoing work to develop an interim people plan to underpin the long-term plan delivery. And so, because genomics is part of the long-term plan, the work I've been doing on the people plan, both the interim one and what I'll be doing to get us to the full people plan, is all about thinking around what we need to do to increase the capacity and capability in all parts of the workforce. So from our more highly specialist workforce, because we know we need more genomic counsellors, we are going to need more clinical geneticists, we need more scientists in genomics, both to support cancer and rare disease, and we also need more bioinformaticians. But we also need to ensure that we develop both prospectively through future-looking education and training programmes, that we embed genomics in all of those programmes for healthcare professionals, but also do the work to upskill everyone in the workforce, everyone in that 1.3 million, because it's equally as important to educate and train managers and commissioners as it is the highly specialised staff if we want to make this work. So we hope the interim people plan will be published very soon, but it's not going to have a lot of detail, but we'll be working on that as we get towards the autumn and the full people plan. And what's good about that is there will be a board that will be overseeing that implementation, so looking towards the future, and genomics and big data is part of that. Now, the second comment I wanted to make relates to actually the implementation of pharmacogenomics into the NHS. So we've got a real opportunity through the results that will be returned through the 100,000 Genomes Project to really look at what is required, rather than assume we know what is required, and how pathways of care will need to change to accommodate those findings. And that will need to start right back and cover the care continuum from primary to secondary and tertiary care. And I would also argue that there may be a role for patients themselves in terms of their own self-medication. Because as I said this morning, is the drug gene pairs we've been looking at are broader than the specialties that we've been including, either within the 100,000 Genomes Project or part of clinical genetic and cancer services now. So we need to be clear about the pathway of implementation, and then we need to target our education and training developments alongside that for the more general pharmacogenomic applications, rather than the very targeted medicines that come alongside cancer or indeed rare diseases, where you've got people like clinical geneticists looking after those who have been appropriately trained. So that, I think, is our challenge, Mania, but I think our substrate, if we want to keep it in a scientific context, our substrate has to be the broader pharmacogenomic findings rather than necessarily the stratified medicine approaches.
Sure, and I guess pharmacogenomics is an example of mainstreaming genomic medicine.
It is, very much so. Yeah.
So, Annika, 2 minute statement. I know you've just done a full. You can make it shorter than 2 minutes.
Thank you very much. So I think perhaps I'm not going to go back through any of the elements that I mentioned in my talk, and also that Sue's just mentioned, but really to say that we will need to work with you guys as experts. We will want to have a team of people that advise us in the genomics education programme around the resources that we need to develop. So we do really need to ensure that we're working with the people that know what we need to implement, and we also need people to evaluate any resources that we develop as well. So I'm really sort of just saying we want to work as collaboratively with people, and so we do want people to show their interest and to perhaps contact us if they want to be involved as well. So that's all I'm saying.
Okay. Okay. So Imran.
So as GP, I mean, the knowledge I start to gain about genomics in practice is based on the information that flows into the practice. So, for example, in the past, we used to get letters from oncologists to say this lady has got breast cancer, we're going to give her radiotherapy, chemotherapy, and she will be put onto hormonal therapy. We now get tumour markers back from the specialists, and in time we are starting to get genetic information as well. So there's sort of knowledge that will gradually assimilate coming into practice. But the other thing about genetics and genomics is what can go wrong. And that really does focus the mind, really. And I wonder, I mean, the genomics educational program is just really far-reaching and really comprehensive. But I think some sort of pitfalls of practice around genomics would, I think, help to concentrate the mind on and think at a practical level about what I need to do for this patient and not run into problems.
Okay, good. That's an important point as well. Okay, so let's try to open this up wider to wider discussion. So can I just, before we start, can you, I just want to take count of numbers of people and what their backgrounds are. How many general practitioners in here, please? So good number, that's great. Hospital doctors? Okay. Nurses? Pharmacists? Brilliant. Okay, well, we've got a wide range of people here, which is great in terms of... Oh, sorry, sorry, yes. Do you know I'm a laboratory scientist then? Please. I thought you were all experts, so I didn't really need to ask you anything. Okay, so good to see. So there's a wide range of people here. So let me start off with one particular question, and in terms of what you mentioned, Imran, before, one way to be able to increase the expertise in, let's say, primary care might be the credentialing process. And I presume you had a discussion about that at the Royal College of General Practitioners, and how that would work. Would it work in general practice? And who would pay for it?
So the old model was the GP with a specialist interest, and I think the reason that worked in practice was because there was local knowledge about who was GP with a specialist interest, who had that special expertise, if you wanted to refer to. And in fact, Jude in genetics is a good example of that. She's well known around the Bradford area and frequently gets calls for advice, I think. Credentially just is another means of extolling some specialist knowledge that's available for local use, really. I thought it was going to be paid for by HEE, but maybe I've got that wrong.
Well, I think this is part of a much bigger conversation about credentialing within healthcare professional development, not exclusively within medicine,
sure.
But across all different members of the healthcare delivery team. So, Imran, I guess the issue will be who pays for it, who has the money, and therefore who's going to pay for it. And I think that's probably an ongoing conversation at the moment.
Unresolved then.
The bottom line will be is to develop the credentials so that, part of this is making sure we get consistency and coherence so that there's no difference in the credential that's applied, but it's applied appropriately in the context of competency. Is what I would say.
Yeah, I think what's quite useful is to remember where we've done similar activities before. For instance, in Nottingham, we ran the sickle cell and thalassemia screening program educational package, and we did have the concept of training the trainers. And we had tried to get the trainers accredited, but at that time the mechanisms didn't exist. I have to say, it didn't affect the dissemination as much as we thought it would, although the feedback from the individual trainers was that they felt that they hadn't gained anything in a paper form to say they'd actually done all that training. As important there as training the trainers was actually to ensure they had the material that was salient to their service. And so it's a whole system arrangement, not just individuals, I would have thought.
Yeah, and I think this is where we found that, as I mentioned in my talk, the development of an educator's toolkit to support educators in, at the moment we're doing this for nurses, but we can certainly extend it to other professions as well. And I think it's really important that we think about the educators and support them and give them some authority or some mark to say that they are educators in genomics too.
Did you have a comment on this, Sue, and then I can open it
So Maria, I was just going to make the point, though, that probably what we're talking about is how we get people more skilled up in genomics more generally, and that's for both primary diagnostic purposes and any sort of additional look-for findings. I think with pharmacogenomics, though, we're in quite a different place, because if we look at the 50 drug gene pairs that we've been looking at, then, as I said a minute ago, that applies in a much more general sense. And we will need to take a different approach to what is required to support that. If going back to this morning, what I said following what you said, which is if there's the potential to influence, if we look at it on even a conservative way, £1.7 billion worth of drug prescribing, then that's going to involve a much broader multidisciplinary team than will be involved in genomics applied to the primary diagnosis of patients. So it's going to be an order of magnitude difference in terms of the education and training component of this. And I think as we work through, and this is just on primary care, as we think about primary care networks, we think about the additional pharmacists that are going to go into primary care. We've got to look at the whole ecosystem that will support a much broader application of genomics in broader use of medicines where people may have significant differences in responses, but also significant adverse drug reactions.
Sure. Do you have a comment or question?
Yeah, it's about pharmacy. So I'm the head of the School of Pharmacy in Bradford, I'm the head of a School of Pharmacy in Bradford, one of the bigger schools in the UK, and also vice chair of the Pharmacy Schools Council. So I think, really to echo your point, we're talking about at the moment things which are developing. We don't have the tests yet routine. So I'm thinking about how that can be mainstreamed into both the undergraduate education, and no doubt I think there's going to be a need to do some specialist postgrad education. And without being parochial about it, I think pharmacists are in a really good position to be the first wave for that, because the agenda of medicines optimisation, this is in wider practice rather than the more specialist centres, is I think where we really need to be. And currently, if we're using these examples in teaching, for example, there are relatively few that we can use. They are more or less hypothetical examples. So it's always going to be a challenge whilst those things are developing. So I think we've got to start with the undergrad. The curriculum has been out to consultation. I don't know whether you've fed into that, but it's not too late, because I think it's a really important thing. But I think there might be a need for a few years to do so.
So can I ask, sorry, in your Bradford curriculum, how many hours do you teach genomics?
Well, it's an outcome-based curriculum, so the hours are not so important. I do introduce genomics in the first year to first-year students with the question about whether a genetic test at the point of admission might affect the use of high-risk drugs focusing on potassium channels, for example, potassium channel blockers. But across the piece, the 30 schools of pharmacy, it is different and patchy, and the educators will have little experience. So I think it's an open door to push against, but I think that the pharmacists...
So is it standard that the General Pharmaceutical Council is trying to develop, that this much genomic education should be developed or delivered?
Pharmacists are trained to go straight into practice. This is practice of the future, so it's always going to be a challenge to design a curriculum to anticipate future practice in a way that's relevant alongside all the other things that are already in curricula. So, it's a problem. I'd be very happy to contribute to that thinking.
So, thank you. I think it would be really useful to have a chat about what we can do and how we can help you. And I think going back to what I said in my talk for the undergraduate curricula, it's often about the genomic concepts, and it's laying that foundation for developing that contextualisation later on in their training, so that when they are qualified and they do and the pharmacogenomics is more established, then they're in a position to really start with the CPD elements of that. But I think we've also got a clear need to think about what we need now in order to get the current workforce upskilled to deliver what's coming. But we need to think about the future workforce as well at the same time.
Bill?
I think it's really important what you say. It completely mirrors my experience in medical education. I think it's incredibly patchy at an undergraduate level throughout the country. We've tried to introduce more genomics into the undergraduate curriculum in the Northwest with limited success. But what we have tried to do with our education lead for the Genomic Medicine Centre related to the 100,000 Genomes Project, so this is Glenda Beeman in Manchester, and linking across towards Northwest Coast, we identified that the FY1s and FY2s have a training programme which they're often looking for new things to add in and looking for people keen to go and teach them. So she managed to get out and give some exposure to genomics to every single FY1 and FY2 in the Greater Manchester area over a year period, and that's been sort of fed out into the Northwest coast area as well. So I think that's it's about looking for opportunities. If you can't change one area, you look and see where there are people that you can go and teach. I think, newly trained doctors are a good group to grab their enthusiasm.
I guess, Mania, just following on from that, we've got an ongoing conversation with Medical Schools Council to try and tackle this at a national level, yeah. And also an ongoing conversation with the General Medical Council to try and influence it from both ways. I think everyone is enthusiastic. It's just how it can be accommodated.
Sure.
And so that's where we are on this, but I think it needs to be more standardised and applied across the country.
So we talked about, I know you've got a question, but just we talked about medics, pharmacists, about nurses, and then laboratory scientists as well. In terms of, is there nurse in terms of what's in the nursing curriculum at the moment with regard to genomics education? So do you want to shout out?
Sorry, I don't think there is anything talking.
There's nothing at all.
No, the new standards have got genomics in there. It's mentioned maybe once or twice.
Okay.
We're talking very much at a very basic level as part of basic science in there. So we have at least got a mention in this latest round.
Mention, but you don't know how that will be translated.
How that gets translated is again something where we're working with the nurse educators to try and ensure that we get a good.
But I think, Hanneke, it'd be fair to say that the Nurse and Midwifery Council are really actively engaged in the conversations we're having about the education and training for nurses, both in their undergraduate programmes and their postgraduates, but also what's happening with nursing associates. And we've heard some really interesting things where genomics have been embedded in nursing associate programmes. But part of the work we'll be doing on the nursing workforce programme is to really understand how the workforce needs to be developed to support genomics, and then that might actually also flesh out other education and training interventions.
Okay, so can I ask about genomic laboratory scientists, and what are the requirements for pharmacogenomics education in the genomic medicine centres, genomic laboratory hubs, etc.? Who would like to take that?
At the current time, as far as I know, I don't think there is anything. So within an STP or an HSST trainee, so this is for a genomic clinical scientist, there's nothing on the curriculum unless a local laboratory decided they wanted to add something in for their local trainee. As far as I'm aware, unless Anna can add to that, but I don't think there's anything on the curriculum.
I have to go and check. I don't know.
Yeah. But
So they should be, shouldn't they? Because that's going to be crucial.
Absolutely.
I agree, it's going to be crucial, but yeah, we're going to have to add it in. But it's not a requirement right now.
It's certainly not going to be there in any sort of significant form to reflect what's coming. So I think we have an opportunity to think about that.
Yeah.
Okay. Sorry, you had a question. Now we're just waiting for the microphone.
Munir, one thing practically, when I look at our Faculty of Health Sciences at Nottingham, within each school there are people passionate about mainstreaming genomics, but they're actually often in isolation. So one practical thing is to bring a network of those people together.
Yeah, so that absolutely, that's really important. But I guess you really have to influence the medical schools as well and the people who develop the curriculum at the time. You know, medical students, pharmacy students, etc. All the professions within the healthcare workforce have a lot to learn. I guess where do you prioritize genomics in that?
Yeah, what I was thinking there is, for instance, in the School of Nursing, there was one passionate assistant professor, but if they could network with other assistant professors in the other universities, that would be a sort of a support network for them.
So I'll give you a specific case study. I have a PhD student who's a pharmacist, clinical pharmacist, and she's doing a survey of pharmacists throughout the country about pharmacogenomic education needs for the pharmacy profession. And she's been hampered by GDPR, but we won't go into that right now, in terms of getting access to these pharmacists. But they all say that it's very high on, that it's important for them, but they actually prioritize it quite low because they've got other priorities. So even though they think it's important, as a priority for new learning, it's quite low. And that's kind of worrying to me. Yeah. Okay, sorry, question.
Thank you. Following on from the theme that Professor Hill, I think you mentioned about pharmacogenomics being different and therefore meriting a different approach. I think there's a strong argument for that. And I wonder, could the different approach be as much clinical decision support as education? Because day-to-day clinical decision support is what you need if you're seeing these problems in your everyday work.
Yes, and it's as equally as important as having the education and training, because part of the dose adjustment that might be required is not necessarily available, for example, in NICE guidance for certain clinical conditions. And so what we know is there will need to be a lot of decision support to enable people to know what to do in terms of dosing and what the evidence is for that. So I think we have to place great importance on that as much as we do with education and training.
Imran.
So the Genex,
get closer to the microphone. So that,
the model I gave in the talk from British Columbia looked at the most commonly occurring conditions in primary care, presenting to primary care, and then they looked at the gene variants associated with those particular drugs, and those were the ones that were incorporated as part of the testing, variants for analysis. So it was a practical approach. It made sense to the users because these were drugs that they were commonly prescribing, and the learning comes with that.
So it's scenario-based learning based on the drugs you're prescribing are the best way to teach.
Yeah.
Okay, please.
Yes, I'm wondering if we might bring it back to education in practice for the workforce that we currently have, because we're focusing, and I think importantly so, on training and educating the clinicians of the future. But we've got a situation when we have the current clinicians who are in less fortunate position, where they just don't have access necessarily to the education and training that they require. And so talking about, I'm just picking up Nadim's point and Bill's point about enthusiasm, is a hypothetical. It's actually a real case, but let's put it hypothetically as if it were national. We have a group of motivated general practitioners who've come off the master's programme, the Masters in Genomics programme, really enthused and championed and encouraged, one could say nagged, but encouraged by a very enthusiastic scientist who understands that locally we need to think about educating the GPs. And I say GPs, we could include GPs and nurses, so let's call it primary care. Mm-hmm. So we have a localised system of education and training on a need-to-know basis for certain conditions that is up and running and ready to go. And I'm in a commissioning role at the moment. And enthusiastically within the CCG, I went to find the pot of money that would enable the localised training of the primary care clinicians, and there is none. There is no access to any money at all for taking genomics out into primary care. And this will be the same. I was thinking about your warfarin situation. One of the learning opportunities that we have within this group of GP educators that we have is to actually look at how we might use genomic testing and warfarin dosing to improve that. And so I contacted Annika about this in advance, very short notice, didn't worry Sue about it just yet, but it really is a stopping point. There's all the enthusiasm locally to prepare something, but absolutely no access to any funding, and it just stops it. Yeah, so how might that possibly be addressed, please?
Okay, so that's an important challenge. Maybe I can ask several members of the panel to answer that. So you go first.
So in terms of actually training of primary care, I think there's GPs from all over the place. We still have a model in the East Midlands of protected learning times. But I'm pretty certain if I went with a genetics half day to them, they wouldn't take it up. One of the things that does work is trying to mainstream it into other aspects of the education. So for instance, if they're doing atrial fibrillation, bring up about pharmacogenomics or warfarin. If they're doing about cardiovascular health checks, bring up about familial hypercholesterolemia. So I think as an entity on its own, it won't get traction. But if you can look at the curriculum that's been sent out there and say, can we have 30 minutes for this slot? I think that's more effective. I don't know what you're thinking, Ron, in terms of that.
Yeah, and I think it also depends on the local population needs as well. So what's important for the population with regard to genomics?
So I'm going to go back to something, though, that I said this morning. At the moment, we're not funding pharmacogenomic tests. They're not on the test directory. So the only pharmacogenomic profiles that will be available will be through those participants that are within the 100,000 Genomes Project, or those that eventually will come out of the WGS, is the whole genome sequencing that's been done as routine care. At the same time, in 2021, when we start to pilot what is a standalone pharmacogenomic panel. So what we've got an opportunity to do, and it's not answering your question directly, Nikki, but as we get the profiles back as part of the 100,000 Genomes Project, because there's an evaluation part of that, is locally, each of the genomic medicine centres that get this back can then start to bring together groups of GPs and others to look at what this means and what is required. And from that, and I think there's different pots of money that can be accessed, but we don't know what it is we need at the moment. And so it might be that action learning sets are the best way forward, which is often case-based. Yeah. It might be a different type of intervention, which is e-based learning. So I think we are stepping into the unknown. What we've got to do is get the evidence to say what do we require to support this. Then how do we align our primary care networks that are on there? There'll be 1,000 of those. They've got new money as well. How do we ensure that we align those with this, and also with the additional resources that Health Education England are putting into GP training as well?
Do you want to follow up with anything on Annika on this issue about continuing professional development?
Only to say, in terms of funding of CPD, I'm not certain how GPs are funded directly through Health Education England, but Health Education England has just sent out a notice of its 50 million workforce development funds to NHS trusts, and that might include CCGs as well, I do not know. But I suspect there's £50 million of funding available for people to access for their own education and training.
And that's transformation, and is, yes, specifically, then CPD is the responsibility of employers.
So you made a very important point about continuing professional development to existing healthcare workforce. So can I ask, has anybody accessed the kind of CPD resources that Annika talked about earlier? So a couple of, there you go, there's several people. That's good, well done. And how did you find it?
Working, you see.
How did you find it? And do you want something different, or was it spot on, or does it need to be modified in any way to be able to help your learning needs?
So I did the UEA Pharmacogenomics course, the MOOC course. It's quite basic, I guess, but I think that for me that was just like, we don't actually know that much more at the minute. So I don't know.
So, sorry, which course was it that you...
The online course that UEA did, the 3-week online course.
Yes, yeah.
So I kind of was going into expecting more, because it kind of mirrored what I briefly got taught on undergraduate level. But
sorry, just to clarify that, when you say the UEA course was just what we know, is that because the course was very basic, or are you just saying that we just don't know enough about pharmacogenomics at the moment and we're such an early stage?
I think maybe just the course. I think we have a lot more, like you guys were talking about some of the studies you were doing, but that wasn't in the course, so it would be nice to maybe have a bit more real life.
Yeah, so I think definitely we have got master's level material through the genomic medicine masters, and then we have a lot of introductory level type material, and we don't have materials that span that gap. And I think that's something that we can think about in terms of what is the next, how do we meet that gap in the middle for people who need more than just a basic introduction but want to take it to a level further but don't want to do a master's level module. But thank you for that feedback.
Over at the back.
Hello. I should probably start by saying this is not my field, so I apologise if I ask an utterly ridiculous question. But I was curious about your ideas or intentions to take advantage of artificial intelligence and its application in this area. So, for example, if you can feed in a certain number of symptoms into a program, and that program has access to the patient's data, they can, the artificial intelligence can, or the computer could basically look at their genetic information and then suggest a number of drugs that are appropriate for that particular genotype. And then obviously the doctor needs to make judgments about the sort of socioeconomic factors that might influence that patient's and their compliance and those kinds of things. But computers are really good at processing massive amounts of data, and considering that someone said earlier GP has 10 minutes to listen to a patient presenting their symptoms and then looking at their history and then being up to date on any changes that have been reported or new symptoms associated with new diseases, it seems like a huge ask to then ask to be up to speed on all of the latest pharmacogenetics sort of advances as well. Sorry, is that just a really rubbish question?
No, it's an important question. So, Bill, do you want to take that, and maybe Sue as well, in terms of artificial intelligence?
Yes, so I've got some artificial intelligence. I think there's great opportunities around that. We've already started thinking about that and trying to work out where we can use it in genomics, but also how we can link into radiology, into pathology areas where you have captured images, and computers, as you say, are fantastic at being able to process that information and then learn from that, and then hopefully mean that we're able to remove some of the human element from that. I mean, one area in genomics, and maybe some of the people from the laboratories would like to comment, but one of the issues that I touched on is about variants of uncertain significance. And it doesn't matter how good you are as an individual, looking at a variant and pulling all that information from different sources is never going to be as good as a computer system that will bring all that together. Now, we're not quite there yet, but that is the direction of travel. And I'm sure that the role of clinical scientists, which in genomics, a lot of their work is focused on variant interpretation and pulling that information together. It's very challenging, but I think a lot of that will change over the future as we use artificial intelligence more, and that those clinical scientists will be employed doing things that help us to go and interpret variants by doing further types of testing, be it splicing analyses or methylation analyses, a whole range of things that we haven't really delved into because there isn't the capacity and the time and to some degree the knowledge to do that, but using knowledge like that to free up the workforce to do other things, I think is something that we should really embrace.
So is there anything is there anything ongoing?
There are lots of pilot projects. We're linked into one which spans across the north of England, led by Phil Quirk in Leeds, around the use of this in digital pathology and linking in genomic data and making diagnoses, particularly around colorectal cancer, but looking to use that for lung cancer and other cancers where genomic information is more immediately relevant. So, but they're just pilot projects at the moment.
So Sue, do you want to answer that?
Just very quickly, I mean, in Genomics England, as part of their clinical interpretation partnership, they do have a machine learning domain that is also looking at how AI and machine learning can be applied. But the bioinformatic pipeline at Genomics England, and Ellie could talk about this all afternoon, but this is a very highly automated process that's algorithm-driven. I think our challenge when we come to think about pharmacogenomics, and there are some commercially available systems, but they're essentially big searchable databases as opposed to applied machine learning. But it's linking the variant with all the different licensed and possibly off-license medicines within that whole database. So part of what we'll have to do is build decision support tools that actually support the drug gene pairs we're going to look at to start with, rather than thinking about everything. But at the moment, thinking through how machine learning or AI might apply when you're trying to have a related database and applying to that would be difficult to see, not impossible. But I think we're at the early stages of that, and most of it will be algorithm-determined decision support.
Okay, Imran, you wanted to make a comment on that, and then I've got a question at the back.
So I agree.
You want to get close to the microphone? Sorry.
I agree it's potentially helpful in terms of diagnosis, but I think another area which will really help us free up our time is helping with back-end functions. And one important aspect of work that we do is extracting data that comes into practices and then putting it onto the electronic health record, maintaining the quality of the record, and then enabling that to be searchable. So if we can use AI to help record quality information, I think that can only be good for patients.
Okay. So you've got a question?
Hi there. I'm a clinical pharmacology trainee at UCLH, just to prove that the speciality still does exist, and there are some of us about. Well, if we talk about an intervention, in particular a medication, we always talk about risks and benefits. We've talked a heck of a lot today about the benefits of pharmacogenomics, but not too much about the risks. I just wanted to know the panel's opinion on whether, when we come to implement pharmacogenomics, at least in the short term, we might cause some harm as well as some good, both in terms of when we come to educate people, this will inevitably push something else off a syllabus. It'll be an additional layer of knowledge, and often I find that a little knowledge can cause quite a lot of harm if you don't know how to handle it properly. It might cause paralysis in prescribing, it might lengthen the decision-making or make it more complicated, or it might sort of just, I don't know, I think it might have unintended consequences. I just was interested in your opinion on how we make sure we get the right level of education to be enabling, not inhibiting.
Okay. Annika, do you want to take that first?
Yes, it's a very good point, and I think we just need to bear in mind that is an unintended consequence, and we need to think very carefully about how we provide a supportive network for people that they have access to information that has been verified that it is the correct information, that they can readily access that information as well, and so that they are supported and that there are networks of people that they can work within in order to ensure that they are that they feel confident and competent. And this is where the competency frameworks and those sort of guidance benchmarks come into play as well. So it's again, I think it's a big area to think about how we protect or we make sure there is no harm that is caused when we're rolling out new services and new ways of doing things at the pace at which we are doing that.
So that's taking it from a education and training perspective. I think there's a service perspective on this, and certainly before we roll out any pharmacogenomic profiles, it would be in the context of being very clear about the evidence for application, very clear about what this means in terms, and by application I mean in different populations, and where there are grey zones, so people are absolutely clear about that. And then what the evidence is for dosing reductions and any other risks. And I think we will have to do that from a service guidance perspective as we roll this out, because this information isn't together all in one place. So no one can go to one place and look for all of this. So we will have to publish this actually as a clinical policy from NHS England to support the rollout, and then gather evidence to collect this. And that's part of what our working group is looking at in terms of what's required to support implementation.
And another area of risk is that we could actually exacerbate health inequalities, because most of the work has been done in Northern European ancestry populations, and there may be some populations where the same variant is not important, but another variant is, and we don't test for that, or we don't have the algorithm which incorporates that. And there's an issue with polygenic risk scores at the moment, which are mostly derived from Northern European populations, but not necessarily applicable to other ethnic groups and so on. So, and the story I gave you about that Asian patient with their carbamazepine was specifically an example of where people were not aware that it was present, it was important for certain populations.
Munir, also. Just a practical point is actually when information comes through to GPs, we do need to make sure it's actually in a packaged form that we can use. To give an example, we're doing a study at the moment on giving familial hypercholesterolemia results to GPs directly. And incidentally, with that comes information on simvastatin myopathy genotype. And the danger there is if we provide that information, most patients now are recommended torvastatin. It might lead to a detrimental effect on giving those patients statins generally. So every piece of information that comes out does need to be properly scrutinized.
Absolutely, but that's where you need to really provide the benefits and risks associated with a particular variant and drug as well. There is now evidence coming out, which has not been published, which shows that you are more likely to come off a statin if you have got that risk variant, even if you have mild symptoms, and that increases the risk of your second heart attack.
Right.
So there is, you need to think outside the box with those kind of variants and the kind of long-term effects it's having as well in terms of non-adherence, stopping the drugs early as well. Absolutely. And there's data associated with the variants and stopping the drug early.
Just one point patients might worry about is how information recorded on the system is used, for example, by insurance companies. And pharmacogenomic data, I think, just applies equally as it does to genomic data.
We've got an insurance moratorium at the moment for the foreseeable future, so there's no intention of insurance companies to use this information.
So the moratorium is already there, and it's going to be extended, isn't
it?
Yes, that's right. Bill?
So the question over there for a lady whose arm was getting very sore.
Thank you so much. Saskia Sanderson, UCL. I just actually had a question, a clarifying question, really. The 100,000 Genomes Project is obviously an incredibly important and valuable learning opportunity. And Sue, you mentioned that the pharmacogenetics results will be being returned to the GMCs. And so I was interested to understand a bit more about whether this is going to be specifically relating to that individual's condition, rare condition or cancer, or whether it's going to be run for every single of the 90,000 people in the 100,000 Genomes Project. And if it were to be the latter,
would then those results be returned to all individuals? Thank you.
So what I can say is the work of our clinical working group that I spoke about this morning is obviously looking at 50 drug-gene pairs where there's cost effectiveness. So that will be taken into account, as well as other considerations in relation to the primary presenting set of symptoms and conditions. So we haven't finalised yet what will make up that final profile that is returned. So it's an ongoing piece of work.
Good question.
Thank you. I just want to know if there was going to be a plan to have a patient education platform around pharmacogenomics, because I think if there isn't one, as you're rolling out sort of a workforce plan in the NHS, you're just going to get more and more people looking on social media for answers. Sort of an official platform that explains, and it will evolve, I suppose, over time. I don't know whether there is already one, but if not, is there going to be a plan for one? Thanks.
Who can answer that?
Annika, that's probably a conversation we'll have when we go away from here. But as we're all charged, though, with really putting the patient at the centre of everything we do, and therefore, given that there's nowhere else we can go for this, I think the issue is how we might use Health Education England and the resource, the expertise we've got there in developing these education and training interventions with organisations like the Genetic Alliance and others that can help us develop patient-facing information.
We work in primary care research. Sorry, work in primary care research, and we're finding that the literacy levels in patients are really quite low, and so the sort of documentation is really quite off-putting, and people won't always admit to the fact that they can't read information. So we are tending in research where we can to try and go more towards video explanations of the research that's happening. But this is what made me start to think about a patient platform of videos to explain, and it would probably help healthcare professionals as well to signpost particular patients with pharmacogenomic issues, I'm going to call it issues, in this direction to have a look and in their own time.
So do you think that if they were given a pharmacogenetic test card like they are doing in the Netherlands, or a pharmacogenomic app, they would take more notice of that and start thinking about it and start looking up online resources and so on?
I think obviously some people would. I think for others, if it's not been explained and they don't understand what it means, they won't necessarily carry it with them in the way that we would expect, or use it in the way that we would expect. So even to have an explanation of what this card is would be useful, or what the different genes related to drugs might mean for them, especially as it's getting rolled out wider. So you'll have a lot of similarities, but I don't know whether you've got any views on that.
I mean, I think, Mania, as you know, there's the card-based system, and then there's education and training that goes patient information leaflets that go with that. There's also been app-based solutions that have been used in parts of the world where there's little resource to support any education and training interventions, and they've been very successful. But I think the point you're making is we have to think about everybody in the population, and one size doesn't fit all. And so, rest assured, we'll make sure that we do that.
Okay, so last word, did you want to say something?
No, I was just going to reinforce what Sue's already said. It's about that can just reinforce inequalities. I mean, we mentioned about 23andMe. I'm sure that if you looked at the demographic of people who have bought 23andMe tests, they're of the wealthier part of our population, shall we say, and maybe more interested in healthcare, etc. And so we have to make sure that people who aren't taken up by that genomics wave aren't left behind and disadvantaged by it. And the only thing I don't know if people have said, but we must do something about the star allele system and all those sorts of things. The fact that it makes people's eyes spin when you start talking about genetic variants in that way, and trying to simplify things, I think is really important.
Okay, so the last question now. Who's got the microphone?
I've got the microphone. So I wanted to pick up on something very important that the lady mentioned. On the one hand, managing patient expectations, which is probably where the GPs will need help, and also their educational package would be aligned with what patients will learn about this new field. And then, so I'm a researcher, and I've looked into when can a GP or a pharmacist actually action a pharmacogenetic test more specifically, rather than everything genomic. So just looking at specific medications and which is the best one to pick based on a pharmacogenetic test. And the insurance companies in the UK for GPs at the moment, they are happy for GPs to utilize pharmacogenetic tests if the GP feels adequately trained. So you're good to go. The test is available. There are labs. They provide accredited tests that can be used in clinical practice. But the GP or the clinician then has that question, okay, so what is then adequately trained? And my question to the panel is maybe specifically to the two of you. What do you think is the sort of level of practical knowledge that a GP needs to have to start actioning such a test in order to have an adequate understanding themselves and also to manage patient expectation? Is it the full level 7 master's degree, or is it maybe a 3-hour CPD online learning module? Where do you see the requirement?
Okay, so maybe GP can answer that, and then maybe Annika can answer that. So go ahead, and then we've got to finish actually.
I wouldn't assume genomic literacy. So I would assume that the level of knowledge around genomics and pharmacogenomics is relatively low. And so I don't think it needs a complicated package of education. It needs to be essential knowledge that is bite-sized and understandable.
I think assessing competency is something which I think lots of people ask us about. In genomics education programme, we don't assess competency, and by doing a course doesn't make you competent to do a certain action or to order a certain test. And that is something which is really sort of for the practitioner to know the limits of their own knowledge, and to know who to contact if they don't feel competent to deliver a certain test or whatever action that they're trying to take. But I think it is a valid point to think about how do we measure competence and who measures competence, and we have to sort of build that in. That's right, and they could be just too scared and not recognise that they are competent, and there just needs to be more skills-based learning and practice and sign-off.
I think I'm not wanting to take the last word, but I just think what we have to remember, though, is the pharmacogenomic testing that's going to be done will be done within specialist laboratories. Associated with those reports, with that result, will be a report. And I think what we have to do as we take this forward is make sure the report is informative enough for the general practitioner to feel confident in taking action, and then to support that with additional education and training to support their broadening of their knowledge as different presentations appear, or where there's a risk-benefit profile associated with it. I think that's part of what we've got to do, and the reporting from the laboratories will be critical in this.
So the interpretation is critical, and this is what I mentioned in my talk, is that when people go to different companies, the reporting varies quite a bit, and that's a danger to patients as well. So having a standardized reporting based on evidence from the NHS will be hugely important for the patients in the NHS. Okay, on that note, we will finish. I want to thank the panel. Thank you very much.